Right, hello. I think we are ready to go. Welcome to this webinar on wound care. My name is Una Adderley and I'm the Director of the National Wound Care Programme for England. I'm absolutely delighted to have with me today Professor Julian Guest and Jackie Fletcher. Julian has worked with the National Wound Care Strategy Programme since the beginning. In fact, I would argue he was instrumental in really highlighting with some actual data the size of the issue. We're enormously grateful to him, and he's going to talk to us today about his work. And then we're going to be followed by Jackie talking about what the National Wound Care Strategy Programme is. Sorry, a bit of feedback there through me. What the National Wound Care Strategy Programme is doing in relation to improving care for pressure ulcers. Please feel free to put questions in the chat box. I will be going back to the chat box. We'll see how things go. We may take some questions after each session, or we may get to the end and then address those there. But we'll keep an eye on the chat box and see how things go. So welcome, Julian. Lovely to have you on board. And shall I pass things to you? Thank you very much.
Thank you very much, Una. So,
are we okay there?
Just looking for the next. There we are. Yes. Okay. Good afternoon, everybody. So we previously published the burden of wound study, which looked at the impact that wounds were having on the UK's NHS in the year 2012-13. And the study found that there are essentially 2.2 million patients with a wound in that study period that were costing the NHS approximately £5 billion to manage purely for wound care. At the end of last year, we published an update to the burden of wounds study, which looked at the burden of wounds to the NHS in the period 2017-18, and we compared what happened in that year to the previous period, 12-13. And the study population for our new study was the anonymized case records of a randomly selected cohort of 3,000 patients from the THIN database who had a wound between 1st of March 2017 and the end of February 2018. And the THIN is a nationally representative database of patients registered with general practitioners. It comprises over 11 million patient records from across the UK, and we were able to obtain the complete medical records, the case records of all 3,000 patients that we studied. Patients were included in our data set if they were 18 years of age or over, if they had a read code for a wound, and if they had continuous medical history. And this was important because unless they died, we wanted to exclude patients who had moved or changed their general practice. Patients were excluded from the data set if they had a surgical wound which healed within 4 weeks of the surgical procedure, since any resource that the patients incurred during that period would be due to the surgical procedure and not to a wound per se. And we also excluded patients with dermatological tumours. So we found that in 2017-18, the NHS managed 3.8 million patients with a wound, which represents a 71% increase in the number of wounds over the 5-year period since 2012-13. And the cost of managing those wounds increased by 48% in real terms over the 5-year period, from 5.6 to 8.3 billion pounds. Despite the increase in number of wounds between the two periods, the actual proportion of wounds that were attributable to pressure ulcers was broadly the same, at 7% in 2012-13 and 5% in 2017-18. And what that means is that in 2012-13, the NHS managed approximately 153,000 patients with a pressure ulcer, and that increased by 31% over the 5 years. So that in 2017-18, we estimated that the NHS was managing just over 200,000 patients with a pressure ulcer, and that equates to 0.4% of adults over 18 years of age having a pressure ulcer in that period. The characteristics of the patients with pressure ulcers was broadly the same in both periods in terms of age, gender, blood pressure, etc. However, what was different was the comorbidity profile. In our current period of 2017-18, we found proportionally more patients had musculoskeletal disorders and neurological disorders, but fewer had cardiovascular disease, and fewer had dermatological conditions, and far fewer patients were documented as having been suffering from malnutrition. So the ulcer healing rate in 2012-13 was 42%. So this is all the wounds in that study period. So that includes new wounds and existing wounds that pre-existing from the start of the period. And that healing rate increased from 42% to 60% in 2017-18, representing a 43% increase in healing. However, with pressure ulcers, the healing rate can vary according to category of ulcer. And in a previous study where we looked at several hundred patients with a pressure ulcer, these are the healing rates that we found stratified by category. And you can see that the healing rate becomes poorer, deteriorates in association with a more severe category of ulcer. If we just remove the category 1 for a moment and just look at category 2 to 4 and the unstageable. So these are the healing rates from onset at 12 months. So at 12 months from onset, we expect 69% to be healed, 69% of category 2 ulcers to be healed, decreasing to 21%, and 36% for unstageable. If we now look at ulcers in that period that hadn't healed in the first 6 weeks, we found that the healing rates deteriorated. So from 69% for the category 2, it deteriorated to 59% and so forth. And you can see how the rates have come down. So if the pressure ulcer hasn't healed within 6 weeks, the probability of healing deteriorates. And obviously, the longer the patient has the ulcer, then the poorer the healing rate becomes. Coming back to our burden of wound study, we found that the healing rate was affected by the documentation in the patient's records of the patient having an infected wound. It was also affected by whether the patients were a smoker or non-smoker stroke ex-smoker. As you can see, patients who were current smokers at the time of the study, their healing rate was at least half that was observed for the ex-smokers and the non-smokers. So from the time of onset until healing for the wounds that actually healed, we found that the overall time from onset was 4.7 months. And this isn't just the wounds that developed in the study period, because we had the complete case record. So this is a wound that may have developed before our study period, but healed in the study period. But for the wounds that did not heal, from the time of onset until the time we received the data set, patients with an unhealed pressure ulcer had that ulcer for a mean of 50 months. We then looked at the healthcare resources required to manage the pressure ulcers. And I've just put up some of the key resources here. And what you see is a big increase in the number of district nurse visits, healthcare assistant visits, general practitioner visits, and practice nurse visits. However, there was a decrease in the number of referrals for hospital outpatients, and there was no change in the number of hospital admissions and no change in the number of specialist nurse visits. And that translates into a cost in the study period 2017-18 of 572 million. So in other words, the actual expenditure incurred by the NHS for managing pressure ulcers in 2017 increased by 2% in real terms compared to 2012-13, where it's £531 million. The resources that make up those costs are essentially the district and community nurse visits, the healthcare assistant visits, and GP visits, which collectively make up nearly 80% of the total cost. And the hospital admissions, prescribed medication, and everything else makes up another 20%. This graph just compares the contribution of all the resource items that make up the total cost, and what between the two periods. And what is particular interest, apart from the fact that you can see the costs in 2017-18 are driven by the human resources, in other words, the nurse visits, the GP visits. What we found is that in 2017-18, there was not necessarily less use of pressure relieving devices, but certainly far less documentation of their use. So in 2012-13, over £130 million was incurred on the use of pressure relieving devices, whereas in 2017, documentation was negligible and the costs were negligible. So the reflection of what I've just presented is that in 2012-13, 80% of all the costs in managing the pressure ulcers were incurred in the community, whereas 5 years later, that is over 90%, less than 10% of all the costs for managing the pressure ulcers was incurred in secondary care. So if we look at the impact of non-healing, so if we take the pressure ulcers overall, 60% healed in the study period and 40% did not heal. But that 40% accounted for 84% of all the costs of pressure ulcer management. In other words, the healed ulcers only accounted for 16% of the total cost. So clearly, healing a pressure ulcer and healing it quickly is critical to improving the outcome for the patient, leading to less healthcare resource use and less NHS costs, and therefore that frees up resources for use by other patients. So just to put it all in context, the pressure ulcers in 2017 accounted for 7% of total costs of managing all the wounds in that study period, 572 million, compared to total cost of wound care in that period, which was 8.3 billion. So just to conclude, over the last 5 years in the UK, the number of pressure ulcers managed by the NHS increased by 31%, the healing rate of pressure ulcers improved by 43%, and the cost of managing these wounds increased by 2% in real terms. And this is a reflection of the healing rates having increased faster than the annual number of pressure ulcers. Thank you for your attention, and I now hand back to Una.
Thank you very much, Julian. Depressing, but not entirely surprising finding, I think we would say. I had a question for you, but actually Kate Hancock has posted one already, which sort of overlaps with mine as well. And Kate asked, given the challenges in community care currently due to COVID, do you foresee further prevalence rate increases? And I was going to ask, since the last cohort, so that was obviously data before the pandemic, and have you got any thoughts as to what's happened to the numbers? And I wondered if it might be helpful to try and address this together.
Well, I don't want to speculate.
No.
I think it's very dangerous to do that. But what I would say is that I'm about to start on a new study looking at the management of some specific wounds in the period before the start of the pandemic and the period after the pandemic. So I'd rather wait till I've got the results, because to speculate based on the anecdotes that I've heard, I don't think is...
No, it's a cruel question to ask a statistician, a health economist, I'm sorry, but we had to ask. So
yes.
It'll be very interesting to see what your next piece of work pulls out. So thank you very much. Right. Well, I think after knowing that we have a challenge on your hands, and I'm a community nurse by background, so I feel the pain of community nurses particularly. I think the best useful thing I can do is ask Jackie to tell us about the work we're doing with the national programme. And as I say, Jackie's been working with Stop the Pressure for years, and we're working in partnership with the National Wound Care Strategy Programme. So I think if we hand across to Jackie, she can tell us on what the work is that's going on now, and hopefully how we're going to be addressing the challenge that Julian's laid out to us. Thank you very much.
Thank you, Ewan. Good afternoon, everybody. And it's quite nice to follow on from Julian, who I think has set the scene beautifully for me to tell you about what we are doing in the programme. If you're interested in any of the resources that I mentioned, there is a table here that we've put into the offer button. So please don't feel you need to scribble any of the links down. That this table you can see on this slide contains every resource that I'm going to mention and all the links so that you can find them all in one place. So I think what Julian has very carefully outlined for us is that we do still have a problem with pressure ulcers. Although we have seen some improvements, certainly in healing rates, we've also seen an increase in the numbers. And some of the things that we are very aware of and that come out through the whole of the burden of wound studies are particularly about unwarranted variation. And I'm sure you're all very familiar with that when you speak to colleagues about how things are done very differently between organisations. And it's very clear that in leg ulcer care, for example, we know exactly what to do. We know that we should be doing Doppler assessment and we should be applying compression where appropriate. It's a little bit trickier in pressure area care because the evidence we have to underpin things is a little bit more scarce. But we do have some evidence, and what we know from work done by some of the teams in Manchester is that there is underuse of the evidence-based care that we have, but actually overuse of some of the ineffective interventions. We know that care is poorly organised, and that's not a reflection on any particular individual. It's about, in the past, there's previously been a lack of an organised structure, and one of the things that the National Wound Care Strategy is striving very hard to do is to put some structure and standards behind what we do. But one of our big challenges we have, and that's become even more apparent over the last 18 months, is a lack of data and information to inform quality improvement and drive forward where we want to be in the right way using the evidence that we have. So what we're trying to do in the Stop the Pressure programme is to think about more strategic ways of carrying out improvements rather than just looking at small pieces of work. We want to do things that have an impact across the whole of England. And this, broadly speaking, falls into four main areas. We need to look at the data we're capturing. Many of you will have been involved in capture via the patient safety thermometer, and I know that for a lot of you this was something that was very much a task. It was something that happened one day a month. It was in addition to the clinical work that you did, and it detracted from the clinical work that you did, and you didn't always get the feedback from it. So we want this to be better than safety thermometer was. We want to ensure that we're implementing better standards of care and that we're implementing them in a consistent way across the country. And part of doing that is making sure that we have education to underpin the care delivery and that that education itself is standardised so that we're all singing from the same hymn sheet. And a very big element of improving our preventative activity, I think, is raising awareness of pressure ulcers with patients themselves and with the general public. We really need for pressure ulcers to be a bit like the FAST campaign for stroke, so that patients know and the general public know that they need to contact us as soon as they feel they have problems. So to ensure that we have the right data and the right information, we need to make sure that we're all saying the same things and using the same language. Now, some of you may be familiar with the 2018 revision to the definition and measurement document. This was the first attempt from the Stop the Pressure programme to standardise the language that we used. And as with many of these things, once it was implemented, what we started to see there were some things that needed a little bit more clarity, that needed untangling a little bit more. And so we are working on this document presently to try and look at some key areas. And I'm not going to read all of these out, but for example, one of the things we know we didn't pick up on was ensuring that we are representing dark skin tones, and we're making sure that assessment in those areas are flagged up really carefully. We didn't specify how to record a pressure ulcer that had recurred on the site of a previous pressure ulcer. So some people recording that as a new pressure ulcer, Some were recording as a recurrence, so we are going to be explaining what to do there. Some people recorded the number of patients, some the number of pressure ulcers, and particularly in the community setting, one of the big areas of contention and where there's big discrepancy is about how we determine if a pressure ulcer is developing in a patient that's in our care. So if you work in the community setting, you will know that there are some patients that you see maybe once every 3 months for a depot injection or some other kind of generic check. But because you have seen them, your organisation might specify that if 2 months after your depot injection they develop a pressure ulcer, that they were deemed to be in your care because you had an opportunity for assessment. Other organisations don't apply that rule. They say, well, if we don't see the patient at least once a week, then we can't be seen to be involved in the risk because the risks might have changed. So what we want to do is standardise that in the new version of the guidance, which will hopefully be out early next year. This is a piece of work that was done previously, but I think works to help with the standardisation. Again, an area that people struggle with and there's much debate about is getting the categorisation of the pressure ulcers right. This is one of the areas we will be looking at in definition and measurement, but if it's something you're struggling with currently, we do have a standardised tool. And all the images in this tool have been through a consensus program. They've been through 3 groups of people to agree that they think that that is a good representation of the category of pressure ulcer that we have. Now, I mentioned the patient safety thermometer, and for all its flaws, the patient safety thermometer was the only national representation of what we had in terms of pressure ulcers. And you may be aware that Ruth May, who's Chief Nurse for England, is very interested in pressure ulcer prevention. And one of the main caveats of allowing safety thermometer to be halted was that we came up with an alternative method of surveillance to replace it so that we had good information on what was happening nationally about pressure ulcers and pressure ulcer numbers. So what we're trying to do with the new system is have what's called a point of care system. So rather than being like safety thermometer that you had to do in addition to documenting your clinical care, this is something that will be pulled from existing data sets. Now, obviously that requires some work. So we are looking at the quality of routine clinical data input, working both with clinicians, the clinical coding teams and the clinical record keeping teams. And we hope that this will support the long-term aim of improving the continuity of patient care across the health system, because although we are initially starting our work in the acute system in hospitals, looking at SUS data, secondary use services data, we will be moving on to look at community data using the community services data set. And the really common thing that we want from that is use of the patient's NHS number so that we can plot the patient's journey through the whole system and we're not seeing replication of the same patient with the same pressure ulcer appearing as additional harms. I mentioned that in order to improve care and certainly to improve the healing rates, we need to look at improving the standards of care. Now, to do that, it's always helpful to have a baseline. And in 2018, 2019, we did undertake one of the largest audits that has been done. And this was an audit not just of pressure ulcer numbers, but also of the quality of care behind it. So many of you will have seen prevalence studies and incidence studies that talk about the percentage of patients that have or develop a pressure ulcer. And that is useful information, but it doesn't tell you what care was being delivered behind that to contribute to what happens to the patient. So in this study, we audited over 10,000 patients, and these were across 36 hospitals representing 18 NHS trusts. And I think one of the important things to say about this was a checking the patient's audit. This wasn't done from documentation. Teams went into each of these hospitals and they physically examined every single patient that they could. There were a small number of patients we couldn't examine, maybe because they were too sick or they were not in their bed because they were in another department. But where it was at all possible, we physically examined the patients top to toe to make sure that no pressure ulcers had been missed. We also looked at the plan of care and the equipment that was in use. We did this against what is known as the asking framework. If you're not familiar with the asking framework, this is something that was developed as part of the core curriculum. And it's an expansion of the SUSkin document. So we are now including as the care bundle for patients that we assess their risk of developing pressure ulcers. that we inspect the skin and deliver appropriate care. We select the right surface and use it well. We keep the patients moving, either by increasing their mobility or by repositioning them. We manage incontinence and increased moisture. We look at and try to improve the patient's nutrition and hydration, and we give information to the patient, their family, and to our other clinical colleagues. So just to share just one table, and I appreciate this is quite a lot of information and it may not be very clear. I just kind of wanted to show you what we did. So the 18 organisations are down the left of the slide as you look at it, and across the top are some of the elements of this asking bundle. And across the bottom, you can see the percentages that were done. So if we look at risk assessment being completed within 6 hours, which is the NICE standard for risk assessment in acute care, just under 70% of patients had that done. If we look at skin assessment, 88% of patients had a good skin assessment within 24 hours. When we come to care planning, we had 81%. But when we start to look at things like a repositioning regimen, it was only 51% of patients had that done for them. In terms of maintaining standards, we were anticipating the implementation of another sequence around pressure ulcers, about assessment and documentation of pressure ulcer risk. This initially was planned to be in community hospital inpatients and in nursing homes. It was planned to be implemented in March 2020, but as you can imagine, that has not happened. We are now anticipating this will be implemented in April 2022. And the scope has been altered slightly so that this now will only apply to community hospital inpatients. I think a pathway for care is really important to help standardise what happens. And within the National Wound Care Strategy, this has been redesigned as a clinical navigation tool. And if you want to see what one looks like, there's already one in existence for lower limb. We have in draft the pressure ulcer clinical navigation tool, and it was ready to go to stakeholders for consultation. But we felt it would be appropriate to ensure that we had completed the amendments to definition and measurement and the surveillance work to ensure that there was consistency across the pathway with the language we were using. And the same applies to the pressure ulcer standards that we are working on. So the pressure ulcer standards are in the work plan for what we will be doing across 2022, but again will be based on the work we've done for definition and measurement and surveillance to ensure that consistency of language. I mentioned education as being important in underpinning appropriate standards of care, and I think it's so important that all our clinicians, not just nurses, are educated about the importance of pressure ulcer prevention and also what we can do to help pressure ulcers heal. So we have done a variety of activities around this. There's been the core curriculum document, which has been available since 2018. And this looks at delivering education at 3 different levels, at fundamental, intermediate and advanced level. It can be used to guide the setting up of teaching sessions, or it can be used by every individual to look at where they feel they are at and to help personal and professional development. And I think one of the key elements of it is that not everybody will be at the same level in each of the elements of the core framework. So if you take, for example, a physiotherapist looking at the keep moving, they might feel they're at an intermediate or advanced level there. But if you're looking at pressure ulcer risk assessment, they might find that they feel more happy in the fundamental. If you are a senior nurse, you may feel differently. We also have a section in the Tissue Viability Core Capability Framework document, and this is what used to be referred to as competencies, and this helps you decide what kind of skills you should have around pressure ulcer prevention. And the final education element is an e-learning module which sits in the e-learning for health platform and is freely available to everybody, which guides people about pressure ulcer prevention, and again is based on the asking framework. We have done some work delivering focused education resources, and I think it's important to say this was done pre-COVID, but very coincidentally, we did some work with a group of people from critical care, which was a mixture of tissue viability nurses and critical care nurses, who were interested, amongst other things, in the prevention of device-related pressure ulcers. And this, as you can imagine, has stood us in really good stead throughout the COVID pandemic. And one of the really key things that the team identified was this constant challenge to the medical team about going back saying, does this patient need this device? Can we use an alternative now? But they have this STAR format, looking at the patient's skin before you start, making sure it's in as best condition as possible, checking the therapeutic device you're going to use, so choosing the right device in the right size, applying it correctly, and accepting that for patients, unlike the PPE we use, that a percentage leak in things like some of the respiratory masks is factored into their build. But it's not all about masks. This can apply to plaster of Paris, it can apply to catheters and a whole host of things. The importance is to apply the correct size and apply it correctly. So if that is a mask, don't apply it too tightly. Remember, patients often develop facial edema, so you may have to go back and revisit that. And that takes you to the first R, which is the regular review of the skin condition. Most devices can safely be lifted and the skin checked underneath. But finally, the second R is about the reassessment and review of that, ensuring that we are making sure that we're doing the right thing for the patient. If you are interested in particular in device-related pressure ulcers, there is a suite of videos that we put together with the University of Southampton Medical Device and Vulnerable Skin Network, looking at the ways we apply a variety of devices. Again, these are all free to watch, and you can see they've had a considerable number of hits. The final element is about increasing engagement with the patients and the general public. And through the whole of the National Wound Care Strategy, we do this in part through our stakeholder groups. We have regular consultations on all the work that we put out, and we encourage input not just from clinicians, but from commercial colleagues, and very importantly, from patients and the general public. In order to improve our engagement with this, we are currently doing some work with the Patient Experience Network, who are supporting and facilitating that and helping us find better ways of engagement and better pathways into the patients. There's some other pieces of work that don't necessarily sit neatly within work packages. So we are doing some work around increasing awareness of skin assessment in dark skin tones. And one of the things that's very apparent to us and that's becoming much clearer in the literature is that in patients that have dark skin tones, the early stages of pressure ulcer are often missed. Those typical signs that we rely on. So we've been very familiar with programs such as React to Red. Redness doesn't show in all dark skin tones, so we really need to think carefully about how we're assessing skin, because it's very clear that these patients go on to develop much more severe damage than patients with white skin. We are working with an academic group in Bristol who are leading a piece of work looking at the healing of category 3 and 4 pressure ulcers. We are working with Southampton University looking at the prevention of pressure ulcers under personal protective equipment, and we will be publishing a second paper on that, hopefully in November. And we're also looking at the skin care in patients nursed in the prone position. And that was a piece of work that came out during COVID, as did some of the work on prevention of pressure ulcers under PPE. But we are continuing to advance and develop that as we find out more information. So the final things that we're involved in is the kind of international awareness of pressure ulcers. And we are once again championing the International Stop the Pressure Day. We are working with the Tissue Viability Society to raise awareness for this. Our theme for this year is Love Great Skin, because it allows organisations and individuals to be much more flexible and to be much more creative in the resources that we create. And as in previous years, our Stop the Pressure Day activity will be focused on the International Day, Thursday the 18th of November. But we are doing some work, so we're doing a series of webinars across the whole week. So Monday to Friday that week, we will be doing some resources based around skin, not the whole of our skin, because we're only doing 4 days worth. There are a whole host of resources on the TVS website if you want to go and see them. So if you like the hearts we've got here, the word cloud, we have word clouds for each of the elements of asking, as well as some of the Stop the Pressure red dots. We will be running the webinars and doing a whole host of other activities. So I think that's covered just on the surface level, the work that we're doing in the Stop the Pressure programme. There is much more detail, as I said, in the resources that we've given you the links to, and I'll be happy now to take any questions. Thank you.
Well, thank you very much, Jackie. And we have got some questions, so let me just get myself organised. I want to make sure that I'm back to the most recent one. Thank you very much for that, Jackie. I'll start with a question from Linda Collier, who's asked, is the increase in numbers of wounds being managed in the community, has it increased significantly due to hospitals discharging quicker? And I'm guessing, Julian, you'll say we cannot speculate, and I have complete sympathy with that. But do we have a feeling as to whether that might be an issue, or any thoughts around that? Sorry, Julian, I think you're on mute. Well, right at the top, little microphone one. Still on mute. It'll be there somewhere. Just to the top, little round circle with audio on. Jackie, do you want to, while Julian's trying to sort that one out, have you got any thoughts?
I think there is an element of that. Over time, certainly I remember, and I think like me, you'll remember, if we go back 10 years or 20 years, patients were kept in hospital for much longer. We are now discharging them much more quickly. Certainly surgical patients are being discharged much more quickly. Many patients being discharged on the day of their operation, or at least the next day. Julian, are you now with us? No,
you're still silent.
I wonder if Rob can
really help us at all.
But I think in terms of things like pressure ulcers, I don't know that it's about early discharge, because if the patients aren't staying in hospital as long, they're not developing them as much. And the same with leg ulcers. So I think it would apply to surgical wounds, to the surgical wounds, but not necessarily to the others. I do think some of it is about we are keeping patients at home much more. So all the work we're doing around long-term conditions and prevention of admission, I think may be what's increasing that amount of work that's being done in the community.
Julian, have you managed to get vocal? No. We'll have to resort to silence. I don't know what to do. I'm so sorry, Julian. I want to help, but I don't know what to do. Right. In the meantime, then, I've got a question which sort of relates to, and I know the answer is Jackie, but I thought I'd let you answer it. Looking at Julian's work, the problem is clearly landing in the community. It's very obvious, and it's got bigger. So why are we prioritising surveillance in hospitals over focusing on surveillance in community? I thought I'd let you have the joy of answering, because I do know the answer, but I thought I'd let you.
Well, I think one of the most obvious answer is it was an easier start. In the hospitals, there already is a system that we have good access to and is standardised across all organisations. So you may not have heard of the SUS data set, but you might have heard of HES, Hospital Episode Statistics, and it's something that people are very familiar with. And that was quite easy for us to get access to, although it's not been an easy task to work our way through it. When it comes to looking at community data, it is much more complicated. Data sits in lots of different places. Lots of people use very different systems, and we have much more of a challenge standardizing what we are looking for and how we do it. So we took the quick win of looking at hospital data to kind of build the model of what we want to do to allow us to be doing some work in the background with community and finding out how it will work there.
Thanks, Jackie. That's exactly the answer I was expecting. Thank you. Julian, have we got your voice back?
Can you hear me?
I can hear you. It's lovely to hear you. Far away.
Okay, so in our study, in our data set, approximately 85% of all the pressure ulcers were actually acquired in the community, and 10% or so may have been acquired either in hospital or shortly after discharge into the community. So the majority are community acquired, and the majority of those patients never went into hospital. So while patients being discharged may contribute, I don't think it's a major driving factor. I think it's a true increase.
It raises an interesting question, because I guess we won't know how many of those patients were known to community clinicians either before their damage occurred.
Yeah.
So but it raises an issue which somebody I know, I think I was a question I was going to pick up later, about how do we increase awareness amongst the public before it becomes a situation. And I guess I'm going to pick on you again, Julian, because Martin Frenet has, I hope I pronounced that correctly, has asked, has the change in patient age between your first study and your second chart study been a factor in the increase that we've seen?
There's been a change in the age distribution for all the wounds, but not for pressure ulcers. For pressure ulcers, the age is broadly the same in both periods. What has changed is the comorbidity profile, as I pointed out. But the characteristics, apart from the comorbidity profile, aren't certainly not significantly different.
Yeah, that's interesting. I mean, certainly my area tends, as specialism, tends to more be leg ulcers. And when I first came into this work, I thought maybe some of the increase in leg ulcers might be because we have an aging population. But actually, when we started diving down into the figures, that didn't seem, it's not that big, it's not that fast an aging population. It was more to do with actually the care we were giving or not giving that probably had more to do with it. So that answers that one as best as we can. Thanks. Louise Vickery has asked a question, and she's asked, do you think that separating ischemia and diabetic, I'm presuming talking about diabetic foot ulcers, alters the data? Often wounds that have essentially been caused by pressure are not recorded as such if they come under one of those categories. Julian, what are your thoughts on that? I see where you're coming from, Louise.
It's a very difficult question to answer. We have looked separately at the diabetic foot ulcers for another study, and we've looked at another cohort of patients with diabetic foot ulcers. But the incidence or prevalence of pressure ulcers among them is very low, very low.
Yeah. It's an interesting one because certainly Jackie and I are spending a lot of time looking at coding issues, aren't we, Jackie? And we know that coders can only code depending on the description they're given by clinicians. Everybody is so damn busy that it becomes a very unreliable system. Is that a fair comment, Jackie, would you say?
It is, and I think in defence of the coders, one of the things they do is they are very clear in their guidance. You know, they follow the guidance to the letter. So if what the clinician writes is at all vague, so if, for example, you put query category 4 pressure ulcer, that wouldn't get coded because there is a query before it, so it's not definitely a pressure ulcer. And I think there's been a disconnect between what clinicians know and do and what the coders know and do. And neither is at fault, it's just nobody's joined the two together. And I think one of the really important things that we've done with this piece of work is join that together. And hopefully, I don't think I mentioned, we've published so far 2 papers about the surveillance. The third paper is going to press tomorrow, so will be available in November, explaining how we are putting together the new surveillance system. And some of the really crucial things around coding are in there. So if you are in an organisation that, you know, is reporting pressure ulcers, please do read it. It's really important to see how you can improve the accuracy just with really simple things.
Yeah, I hope that's music to your ears, Julian.
Can I just add to that? So for our burden of wound study, the latest one, there are over 2,000 read codes that we used in pulling out the patients, and some of them are just duplication. So the clinicians just document something in text. I don't know how the coders decide which read code to assign. It's a mess, isn't it? Have 20 codes for the same condition.
Yes, we found exactly the same work we're doing, and one of the things we're really trying to do is try and deal with some of this complexity and remove it so that we can start to code things in a systematic way, so we can actually benchmark and make reasonable comparisons, and that we have a better chance of collecting more accurate data. But you're right, Louise, it's a complicated mess. And Jackie, I think we're going to have to add something, maybe definition of measurement about how do you, but that'll probably be for next year. But I think going down the diabetic foot ulcer and pressure ulcer on the heel thing is yeah, it's an interesting one though. But we're also looking at the data and coding, because of course there's overlaps between different types of wounds, and we are looking at data and coding for lower limb wounds as well. So again, I think there's going to need to be some work there. We haven't got there yet. You would not believe the volume of work we're working through in trying to untangle some of this. But yes, it's a good question, Louise, and we are certainly thinking about those sort of things. Ian has asked, the difference in use of pressure relieving devices has reduced, or the use of, is it not being documented, or how do you explain this? I'm not sure who's best to answer that one. Let's start with you, Julie.
I've got a theory about that, actually, and I was thinking about it, because I think an element of it is it's changing documentation, but I wonder if some of it is down to the increased use of hybrid mattresses. So clinicians don't see switching a box on as much as much as putting pressure relieving equipment on, so they don't document it. So if the patient's on what they see as a foam mattress in the first place, and then they just switch the box on, they're less likely to document that than if they take them off a foam mattress and put them on an alternating mattress. So I wonder if there's an element of that, Julian, that they're flicking a switch rather than swapping a mattress, so they don't document it.
It's possible. I think it's a simple question, but it's a very complex answer. I think it's all of these things. I also think there's an element of more and more less experienced clinicians managing the patients in their home, and I think they're very rushed for time. And I just think this is one of the things that gets. I mean, a lot of this is hard copy being written down on hard copy case notes left in the patient's home. It's not digital, and I just think it's just fallen off the wayside. That's what I think. In many instances.
It's interesting. We're also doing a bundle of work around the need to for digitalisation, particularly in community services. As you say, so much of this is still pen and paper, and it's not impossible, but it's extremely expensive and difficult to pull that data or pull that information through into meaningful data that we can then make decisions on. So it's not just about improving care and clinicians recording accurately. It's also about them having access to the digitalisation devices and software, hardware to enable them to record more accurately, and also to help guide them into not having to choose from 100 and whatever many different codes to actually get them to the agreed code. Yeah. Thank you. Claire has asked, Claire Acton, hi Claire, is there anything the national programme is doing in terms of national public health messaging to raise awareness? I'll start with that one. It's probably my responsibility, then I'll pass to Jackie. In a brief, yes, we have a patient and carer stakeholder forum, which we would be delighted. If anybody has patients that they're working with who would like to sign up to that, please encourage them to do so. We don't pester people with information, but it's our way of reaching out. And as Jackie alluded to in her talk, we've also just recently commissioned the Patient Experience Network to start working with the programme, because although we have the best of intentions of trying to make sure that we are both listening to the patient voice and providing information in a format that patients and carers want, we recognise we're not experts in that. And so we've now commissioned an organisation to work with us to help us get better at that. So it is on it's not just on our to-do list, it's one of our things for this year, isn't it, Jackie? Is to try and scope what is needed, because you're quite right, Claire. We need to be doing more, and we need to be doing it better. Jackie, is there anything you want to add?
Yeah, and I think the other element of that is we've now been fortunate enough to just be securing some proper comms support. So at the minute, it's been us as a team, as clinicians, trying to put messages out and making sure they're going out well. But it's not our area of main expertise. So having some comms support to support us in that, in how to frame messages, how to deliver the messages, and how to get them out best, I think will be really helpful.
Yeah. And a lot of this it's not lack of recognition of what we need to do. We have been very constrained by finance. We were working initially the first nearly 3 years on a very tiny budget. And then although we got funding in the long-term plan, because of the pandemic, there was a delay in that funding coming through. So I'd say it's only, I don't know if you agree with me, Jackie, it feels like it's only really the last, even 7-8 weeks, I would say, that we've actually really got motoring with having a team, the team that we expected to have in place. It's still a small team, but we've actually got people in place working now. So it's not just, it is still a few of us, but not quite.
It does feel at the minute like it's all coming together, doesn't it?
Yes.
It feels like we've done such a lot of background work, and we now get to the point where we're publishing things, we're getting ready to implement things. And for those of you out in practice, you may be aware that the National Wound Care Strategy has been around for a while, but you haven't seen anything change. I think that's now at a pivotal point where we've been doing such a lot of strategy work and working out what we need to do and scoping it, and we're now just coming to the point where it's ready to come out, and you will start to see it change. And in some ways, the timing is very fortuitous, because if we'd been wanting to implement these things a year, 9 months ago, it wouldn't have been right. We're just at the right point where people are looking at service redesign and recovery, so it should work quite well.
Yeah. Next one's from Jason Wong, and Jason, one of our colleagues with SIPS. Hello.
Thank you. And I'm surprised saying SIPS are doing this work.
No, Jason's asking, has any modelling been done to determine whether the cost of non-healing pressure ulcers could be impacted upon by better access to surgery? Julian, that has to be one for you. Everybody knows the answer to this.
I'm not aware of any. I'm not aware.
No, we're not either. But yeah, you're right, Jason. It's something that we do need to look into. So hopefully we'll be able to do that with yourselves. Vivian Coughlin has asked a question about, Jackie, we have a case where a person has developed a category 1 ulcer 3 weeks after healing a category 4, presumably on the same site, I'm guessing. We've been wondering how to describe this, so any guidance we should. Before I let you come in, Jackie, I know the answer to this because this is going to be the new definition of measurement document. What I don't know is whether we're going to be sending it out for consultations, what we think should be done. Jackie, are you up to speed on this, or do you want me to answer?
Yeah, I'm quite happy to say that. Our recommendation at the minute, and I will say at the beginning very clearly, this has not been out for consultation. So our recommendation is that if the wound has only been healed for less than 12 months, that is a recurrence. If the wound has been healed for more than 12 months, we would call that new. Now, we've put in the document very clearly that we know this is an arbitrary cutoff. We've looked for evidence, we've looked for research to give us a good guidance, and we can't find any. So we have taken a consensus view and we've said less than a year, recurrence, more than a year, new.
But as Jackie says, we are just putting the final touches to this document that we hope to get out for consultation very, very soon. I've got a call on Monday with somebody, and I'm hoping then we'll have a point that we can get it out for consultation. If you want to put your 2 pence in as to whether you think that's a good idea or a bad idea, please sign up to the National Wound Care Strategy Programme. Follow us on Twitter, because that way you'll know when the consultation comes out and you'll be able to comment. I'm afraid the consultation is only for people working in England, because we are a programme only for England, so we can only take feedback from people also working in England. But we would love to know your views on what we're recommending. So you've asked a really good question there, Vivian, and we also thought that was a good question. So we hope we're coming up with something which everybody will be able to agree with. And if you don't agree, we'd like to know why, because we may have missed something. Oh, it's a long one now. Gosh, a long one. Carl. Paramedics. Yes. Ambulance. I won't read the whole of it, it's all right, because I think you can read it in the chat box. Basically, it's a question about paramedics. Ambulances could easily identify. Yes, we completely agree, but this doesn't happen. I know it doesn't. There is buy-in. I would disagree with you. There may not be a buy-in from ambulance services, but your people at the top of the paramedic profession are interested, because they are now involved and in the last few months have started working with us. So we're absolutely delighted to have you on board, because we agree it's a paramedic issue as well. Hang on, I've jumped. Sorry, where did it go?
I just think it's also worth mentioning, because if you're watching the news at all at the minute, there's a lot in the news about 14-hour wait times and patients being held in ambulances. This is absolutely time to grab the opportunity, Carl. And, Carl's done quite a lot of work on this, and he's actually published, I think it was last month in Wounds UK, and he's presenting for us at Harrogate about the importance of the role of the paramedic. And he's flagged some really important things about how many patients they don't take into hospital. So the paramedic goes and sees them, say after a fall, they've had a long lie, but they've got nothing obvious. So they check them over and then leave them at home with a non-urgent referral to the community nurse. But actually, if they've had a long lie, or even if the ambulance takes 90 minutes to get there, as he said in the question, the risk of a pressure ulcer occurring is quite high.
Yeah. It's an interesting one with wound care, because it's not just, I know this presentation is about pressure ulcers, but it's also paramedics see all patients with all sorts of wounds, get called out to all sorts of wounds. Plus, many paramedics are now starting to work within GP surgeries and things like that. So we agree. We regard you very much as part of our wound care family and would love to work more closely. And indeed, the people at the very top of your profession are very interested in our work and starting to join up.
Julian, I wonder, you mentioned ambulance in your data on cost usage, didn't you? Can you tell from that ambulance how many patients did have an ambulance call out but were not admitted?
I can. I can't tell you the answer, but I do know I do have that.
Might be something worth looking at.
Yes, because it's obviously a very small percentage call an ambulance out anyway. And then we looked at, so they all go into A&E, and we know what happens from there.
Julie, I'm conscious we're running very close to time. Julie, you're asking about getting involved. Yes, please go and have a look at our website. You're very welcome to sign up. And yes, please get your organisations started to make the changes. You may want to look at what the moment's called the Learning Collaborative, about to be renamed the Lower Limb forum, but we're also interested, we're taking applications from organisations about lower limb, but we also love to hear from people who are trying to make changes in practice. So please get involved. Ed Rustling is asking what can be done more to support the role of the TBN. Ed, it's on our to-do list again. We've got it down as a work package we know we need to be addressing, and we're starting conversations. A lot of this is the challenges of the capacity of our relatively small team. So yes, you're quite right, and we have got it on our to-do list. Much more training, awareness, and pressure ulcers. Yep, agree. We also think it's interesting. We tend to think about nursing, but this is an issue for everybody. Everybody who sees a patient. It's not just a nursing issue, and we think we need to get into more pre-reg clinical programs. Do we think sequins will become in acute care? It's much more difficult to get a sequin in acute care because there are so many people vying for sequins in acute care. We can but hope. Whether sequins will continue long term, I don't know. But yes, quality. Whether they exist as sequins or whether they become a quality improvement program in some other way, yes, we'll have to see. But yes, quality improvement is needed. There is a flurry. We'll be looking at post-op wounds. Yes, we are looking at that. Go and have a look at our website under our surgical wounds. We think the current surveillance systems don't work. John, maybe that's a good one. So there's a ream of questions, and I stand no chance of getting to the end because we're due to finish in about 2 minutes. Would it be reasonable? I'm just wondering, we are able to get the questions. Maybe Rob, who's running the webinar, if you want to send us these questions, we can try and address them out of the time. But I think I've got a minute. What should we take as the last questions? Oh gosh, where am I looking? Anybody want to pick one that they've spotted that I've missed?
Can I just make a comment?
Please do, Julian.
Just to say that I'm currently looking at post-operative wounds and looking at incidents of surgical site infections, also looking at this before the pandemic and after the start of the pandemic.
Are you looking at wound breakdown as well as SSI? Because that's an area we're concerned about. You're looking at both. Any wound, that's music to my ears.
And increasing severity, I think, of wounds is really important.
Yes.
And
yes.
Are you looking at late presentation, Julian? Can you identify that how long the patients had the wound before they present to healthcare?
Yes.
I think that's been a big concern, hasn't it, through the period of COVID?
We'll be looking at the patients from the time of the surgical procedure.
We recognise there's a need there. I know we're going slightly off piste here from pressure ulcers, but we recognise the existing surveillance systems. And going back to what people were saying about patients going out into the community much quicker, simply aren't able to pick that up at the moment. So we know we need to be doing something about that. I think as we have 1 minute left, I had better thank you for all particularly my speakers, Jackie and Julia. Thank you so much for your contribution. It's lovely to see so many questions. If Rob, who's organising this, is able to send us those, we are happy to try and come up with some answers we can post. I'm not sure if that technology permits. But thank you, everybody, for coming and joining us this morning and for your participation. And it's just lovely for us who work in the central team to see the enthusiasm that's out there for improving wounds. And thank you very much for your time today. I think we're there.
Thank you. Bye.
Thank you. Bye-bye.
Bye-bye.